Thank you very much. The invitation or the introduction I was inviting, I thought I'd give myself a European flavour today, and I thought I might be introduced as bon vivant, raconteur, bullshitter. Anyway. Okay, so my mandate today is to talk about recruitment beyond the routine application in ARDS. But I think it's important when we talk about recruitment to find, first of all, what is adequate recruitment. And we're really very indebted to Gattinoni, who did CTs and described three very functionally distinct regions in the adult lung with acute lung injury. The least dependent area, which remains inflated throughout tidal ventilation and is at risk of overdistension injury, and that's controlled during protective ventilation with a plateau pressure less than 30. Nothing new there. The intermediate zone, which collapses and re-expands during each breath, is at risk of collapse re-expansion injury, and that's hopefully minimised by the uses of higher levels of PEEP. And this is the basis of protective ventilation. And so the protective ventilation takes care of zone 1 and zone 2, but the most dependent collapse throughout tidal ventilation region is not helped with protective ventilation. And hence there's been a lot of interest in prone ventilation, partial liquid ventilation, and recruitment, and oscillation, of course, we should put there to try and get to this area. And of course, in most adults die from multiple organ failure, not because they're unventilatable. And we know that this lung, once it's injured from its native injury and also by the ventilator, that it produces a whole lot of injurious cytokines, which we believe have a major role in the generation of organ failure and death. And we know that when we use protective ventilation, we get less death and less multiple organ failure. So we think in our mind that we've switched off the cytokine production as much as we can from zone 1 and zone 2, but zone 3 is still manufacturing cytokines and contributing to mortality, hence our interest in recruiting that zone. But what is good recruitment? Well, there was three major trials looking at higher pressures in recruitment. Alveoli, which we all know, large trials using higher PEEP and recruitment in a small subset. Loves, even bigger trial using higher PEEP and recruitment in all patients, and Express using no recruitment. And all these trials didn't have such a great increase in PEEP. They all increased plateau pressure. They all had a trivial reduction in mortality, but none of them was significant. And so, but the key point here was that they were all using the 40-40 manoeuvre, even though it had been shown by Luckman that you needed to take the pressures up to the mid-50s, sort of 60s, because that resulted in apnea, hypotension, and the eyes bulging and patient discomfort. It was watered down to a manoeuvre which was better tolerated, but was not effective in these trials. And so we designed a staircase recruitment manoeuvre, and this is the new era of recruitment manoeuvres. And this is the early version of it, not the current version of it. And basically, in pressure control, the pressures are stepped up to 20, 30 and 40 centimetres of water, and there's a superimposed pressure of 15 plus or minus 2, depending on body size, which brings the total alveolar pressure up to the maximum at 55, give or take 3 centimetres water. Now, this steps on the way up are to make sure that the manoeuvre is tolerated, and the steps on the way down are a different staircase, because the maximum PEEP you'd ever want to use is 25, and the minimum we believe should be 15 if you're bad enough to need this, and we're looking for the first point of desaturation in this manoeuvre. So why is this better? Well, because it's intermittent, it's better tolerated, and so you can leave it for longer. So this manoeuvre has three key features. The pressures are higher, but not only that, it is it's intermittent, which means ventilation continues, and we believe the intermittent nature itself is better at recruiting the lung than a static manoeuvre, and of course it goes for longer. And we've seen in the previous speakers' slides that there is recruitment over time. If it's short, you might not achieve full recruitment. So, and this is a case of a 35-year-old man who's had an appendicectomy, had severe aspiration injury, 100% oxygen, 10 of PEEP, saturation 85%, just about reaching ECMO criteria. And we did this recruitment manoeuvre on him. And you can see here he is on 10 of PEEP, 15 of pressure support, 90% saturated. Here he is on 20 of PEEP, 15 of pressure support, going up to 20, still 90% saturated. 30 of PEEP plus 15 of pressure support, 91% saturated. So here his pressure has reached 45, and if he was having a 40-40 manoeuvre, you would have concluded, as they did in the last two studies, that he was a non-responder, and in fact he was. But when you put the pressure up to 40 plus 15, all of a sudden things pop open. His critical opening pressures were not reached by a 40-40 effect, but at 100, he went to 100% saturation. When he came back down to 20 of PEEP, he maintained a saturation of 98%. And you can see he got a bit of air into his stomach prior to his reintubation. So, and we've done a whole lot of series in this manoeuvre, on this staircase recruitment manoeuvre, and we're not the only ones, of course, that compared with 40-40, about a third of patients desaturate during the manoeuvre. And that is a reason to abandon the manoeuvre because you assume it's not working. But in fact, the 40% of patients who desaturated, who might have had their manoeuvre abandoned, in fact, they finished up responding and having a significantly improved saturation. And the transient desaturation at high-level PEEP is mainly a circulatory effect due to cardiac tamponade, if you like, which only goes for a couple of minutes and has full recovery in the next couple of minutes afterwards, and also to adverse blood flow redistribution at those high pressures. But the desaturators, when the PEEP comes down, finish up having a response. So in the staircase manoeuvre, if you'd abandon it for desaturation, then you miss out on the response, the responders. And there's another about 15% whose saturation went up who didn't get their high response until we went up to the maximum pressure. They would have been 40-40 non-responders. So in this first study we did, we estimated only about 45% of patients would have responded to a 40-40 manoeuvre, but we had a 90% response rate, and we weren't to be put off by desaturation. So the first point is, when you're doing recruitment manoeuvres, you've got to make sure that you're doing one that is effective, not an ineffective manoeuvre. Not all recruitment manoeuvres are the same. And this represents the staircase manoeuvre, the new era of recruitment manoeuvres, which have been looked at in the FARLAP study that we're doing, that has been recently reported by the OLA study by Kazmarek in the States, and which Amato is doing in the ART study in Brazil, or he's involved in it. So 40-40 is heading in the right direction, but it just hasn't quite got it right. Took me a while to figure out what was wrong here, but I got it. So, and we, of course, have done a study looking at this recruitment manoeuvre, small randomised study as a precursor to the main FARLAP trial, which has shown that we get a much better improvement in PF ratio over a week and a better improvement in compliance. And we had, in a tiny study where we couldn't possibly have significant outcomes, very tantalising reductions in length of stay, hospital, ICU length of stay, hospital length of stay, and length of ventilation. And that's what got us into the trial. But we're not here. My mandate today is to talk about recruitment. Does this recruitment have a role outside the routine use in ARDS? And by ARDS, we now mean moderate to severe ARDS by the Berlin definition, PF less than 200. And we believe it has a role in all these conditions, and I want to show you examples for this. And of course, there are no large randomised trials on any of these things, and so it is all case reports and anecdotal evidence. But it is pretty compelling, and I'd like to take you through it. So first of all, we receive patients for ECMO, remote referrals and retrievals. And we now routinely apply this manoeuvre to patients referred to us, and here is a case report here of a person meeting ECMO criteria, 90% on 90% oxygen, saturation mainly in the 80s. And this person went up, recruited to 57 on 40, with the tidal volume down to 200 on pressure control ventilation. Saturation went up to 90%, 98%, way outside ECMO criteria. The FiO2 was able to be turned down. The X-ray had more air in it, and this patient was retrieved on high-level PEEP and never needed to go on to ECMO. And she had a long and difficult course, but was weaned after 2 weeks. And over 5 years of our ECMO referrals, there is about 7 out of 45 patients who are clearly rescued by the staircase recruitment manoeuvre. There's about another 8 out of 38 who had recruitment manoeuvres prior to vena-venous ECMO and had to go on. So the majority didn't have recruitment manoeuvres in this early series. So about 7 rescues and about 8 failures says about a 50% response rate. But in reality, we believe that it's at least a quarter, anything between 25 and 35% of all our patients meeting ECMO criteria are rescued, or if you like, improved sufficiently that they do not need to go onto ECMO by this staircase recruitment manoeuvre. Some of them have had other manoeuvres beforehand, but we would still want them to go through the staircase manoeuvre because we believe that's the most definitive manoeuvre. This also begs the question as to what is the best ventilation during ECMO. Do we rest the lung? That was a traditional thing. Gee, the ventilator's damaging the lung, too much inflation, too much pressure. So low respiratory rates, low tidal volumes, low PEEP, deflate the lung. But we've found in adults, this gives you a very unhealthy lung. It's like that collapsed lung zone spreads throughout the lung. It's never adequately ventilated, never adequately drained or oxygenated, and it gets a lot of infective damage in that lung, and we finish up with that lung full of pneumatoceles. So the next step was to move to lung protective ventilation, put the PEEP over 15 and low airway pressures. We believe that's healthier. But why? Maybe we should be opening the lung. That might make it an even healthier lung. Why wouldn't we do it just because they're on ECMO? And again, I'll just show you one of several examples we've got. This is our most dramatic flu epidemic, a lady who was put on ECMO without recruitment, and on the day she arrived, we gave her a recruitment manoeuvre. Her saturation went from 94 up to 100% and was sustained, and we were able to decannulate her the next day just with recruitment. We've had several other patients in whom we've done recruitment manoeuvres. They've had significant improvement in oxygenation and ventilator appearance, but not good enough to come off ECMO. But nevertheless, we believe they have a healthier lung with better aeration, and their lung is in a better position to recover. Now, single lung transplant for COPD has gone out of vogue these days. We're not doing so many, but nevertheless, they are done occasionally, and the lungs are often injured. And there's a unique phenomenon that happens with single lung transplants. You get an injured lung, it collapses down, and the native lung, when you try to ventilate this whole thing, undergoes hyperinflation. This lung gets big and black and squashes the mediastinum over that way. This injured lung can't get air in and gets even more compressed. You have an irretrievable imbalance. And so one way of overcoming these quite different ventilatory requirements of these two lungs is to put the patient on independent lung ventilation. And you see here a lot of complexity, but basically a double lumen tube has been placed, and we've got 2 ventilators. And just so that we didn't get confused, we labelled them number 1 and number 2. And we applied completely different patterns to the lung. But here's the thing, and this is the result that you see. That lung, which was whited out completely, in fact was amazingly well inflated, and this lung was deflated. And a key part of that deflation is not just to put standard protective ventilation, but in fact to do a recruitment manoeuvre on this lung. So same pressures, half the volume. So this lung had a recruitment manoeuvre, the pressure control, and we did it with more caution because there's an anastomosis there and we're cautious people. Pressure control 12, tidal volume half the standard 6 mils per kilogram for obvious reasons, high rate, high PEEP. This lung, of course, doesn't need recruitment, low tidal volume, low rate, and no PEEP, allowing the whole thing to deflate. And you can see on 0 PEEP, it's still hyperinflated. And so this role of recruitment here is an essential part to the independent lung ventilation of this acutely injured transplanted lung. And of course, recruitment has been done during non-invasive ventilation. And this is a study by Barber, small study, 8 patients. And here they just got somebody to stand there and drill the face mask on. It was what we call the Bert Newton face mask, the moon face with the big pressure tire around the edge. And the pressures were held up to 20 and for 2 minutes. And you can see, here's a typical example, but probably their best example. You can see here this patient with acute lung injury had dramatic improvement in X-ray appearance and oxygenation, with an average PF ratio improving quite significantly across 8 patients. There's been very little further work of this, and of course we now know that you have to use non-invasive ventilation carefully in acute lung injury. So if you haven't got a really good response, it's important to bail out early and intubate these patients so they can have more definitive PEEP control. Now we're getting into the other areas which are outside ARDS, and we see an awful lot of lung collapse, and so we very often want to put the PEEP up or give additional chest physiotherapy. But we now are starting to use recruitment manoeuvres to this group. And here's another typical example of a 55-year-old man intubated for a stroke. Again, the big gastric bubble here. And you can see here there's what looks like a high right diaphragm, but that is in fact the horizontal fissure. So he's got complete bronchus intermedius occlusion with right, middle and lower lobe collapse. And you can see here that after bronchoscopy, this patient has been sucked out, but the lung remains deflated, and so it hasn't got good gas exchange. So maybe with time this would come good, but in fact we did a recruitment manoeuvre, 12 PEEP up to 12, up to 40, and then back to 15, pressure control, lung fully inflated. And I can go and show you more examples of this, but this is a very common phenomenon. This person hasn't got acute lung injury, but they have got, they do have lung collapse, commonly basal collapse, and it is not inflated by the high levels of PEEP, and often the response to physiotherapy is sometimes good and sometimes not good. But when you do apply a recruitment manoeuvre to this group, you very commonly get a very gratifying response, improvement in X-ray appearance and improved oxygenation, which was your goal of therapy. Here your goal is to improve X-ray appearance rather than primarily addressing gas exchange, and believing that by improving X-ray appearance, you're improving lung health and reducing time on ventilation. And of course, we now have electrical impedance tomography coming in by those who can afford the machine, and this is a great way of looking at patients who have poorly inflated lungs. It's an even more sensitive X-ray even more sensitive tool than chest X-ray, and of course you don't need to go off and have a CT. It can be done at the bedside, and you can see the response to your lung recruitment manoeuvres by watching the effects on impedance, and this has been shown by a number of other speakers, both in this and other sessions. So what else can we do it for? Well, it's now been recognised that it's of value in organ donor recruitment, and here's 2 cases. 65-year-old brain-dead man, morbidly obese, had an intracerebral subarachnoid hemorrhage. Chest X-ray was clear, but he was on pressure control on 8 of 15. His PF ratio was only 239 on 100%, and that meant he didn't fulfil donor criteria. The PO2 is meant to be greater than 250 or preferably 300 on 100% oxygen to be a lung donor. After a recruitment manoeuvre, you can see his PO2 went to 400. He could then be considered as a donor, and he was in fact successfully donated. Another person, 59-year-old, DCD, donation after cardiac death, obese, again, chest X-ray, clear. He had a CT-PA though, to diagnose pulmonary embolus, which he didn't have, but this in fact showed extensive atelectasis. And on pressure control 15 of 20, he only had a PF ratio of 190. Again, that would have ruled him out as a donor, but after a staircase recruitment manoeuvre, dramatic improvement in oxygenation, and he was then became a successful donor. So here is patients, they don't have lung injury, they don't even have a radiological collapse, but they have a PF ratio, an oxygenation status that precluded donation, and that was rectified with a recruitment manoeuvre, which then enabled successful and confident lung donation. And lastly, I want to finish with a case which shows another completely different application. And this is the case of a 45-year-old Indigenous Australian man who'd had bronchiectasis since he was a child and had a bit of alcohol-related cardiomyopathy. And there's his x-ray 18 months prior to the story that I'm about to tell you. He presented 2 months prior to us or me seeing him with right-sided pneumonia, no doubt related to his bronchiectasis. He was commenced on antibiotics and he had this x-ray taken, but unfortunately he left the hospital, absconded, before any further x-rays or treatment could be administered. He then returned to the hospital 2 months later with abdominal pain, severe abdominal pain. And at the time, he had a chest x-ray and he had extensive right-sided consolidation in this lung. And with only a small bit of air in probably the apical segment of his upper lobe. And he had a CT done at that time, which showed extensive consolidation, maybe a bit of fluid and extensive bronchiectasis in that lung. He also had an abdominal CT, which was completely normal, and it was concluded that his abdominal pain was in fact diaphragmatic pleurisy, and his problems were primarily pulmonary. Now this, we believe, was a life-threatening issue. Lungs like that don't stay infection-free for very long in a patient with bronchiectasis, and although he was afebrile and had a normal white cell count, saturating about 80% on air and about 90% on mask oxygen, he's a sitting duck to get a lung abscess and an empyema and probably not make it. So we were very keen to try and fix this. So our first thought was he might have a blocked bronchus intermedius. So we did a bronchoscope, which he tolerated very well, to try and fix this. And we found no occlusion. His airways were clear and patent, but we did manage to suck out that last little bit of air from his apical segment on the right-hand side. So far we haven't done him too many favours. So we thought, okay, we'll put him on CPAP and give him active chest physio, deep breathing and coughing and so forth. And we did that, 24 hours of CPAP, completely no effect. So this is obviously a chronically glued up lung. So we thought we're not trying hard enough. So we put him onto BiPAP, higher pressures, hard to sustain, for 24 hours, and really worked really hard on the percussion and posturing and deep breathing and coughing and everything we could do. And we just got that little bit of air back into his right upper lobe. So we thought, okay, we're going to intubate him and do a recruitment manoeuvre because we believed this was a high risk to this man. And I told him that I was going to put him to sleep, and he thought putting to sleep was something that the vet did, and so he wasn't happy with that at all. So he did consent to awake nasal bronchoscopic intubation with no sedation, which we did, and we intubated him, and we recruited him twice, 2 minutes each time at 50 centimetres PEEP plus 12 of pressure support, equaling an alveolar pressure of 62, and then returning to PEEP of 20 with a 12 of pressure support. And you are expecting me to say at this stage, and look what a dramatic response it had. There it is. So absolutely no difference. So what should we do at this stage? Again, this is not ARDS. This is not lung collapse. This is not oxygenation failure. This is a chronically glued lung. So we thought we would push on with his care. So he remained on PEEP 17, pressure support 12, and we repeated his recruitment to 50 every hour, just 2 minutes. So you said the airway pressure limit up. The nurse there just got a watch out, turned the PEEP up to 50, and he tolerated it very well, waited a minute and put it back down again. And amazingly, at the end of 6 hours, the tide was starting to go out. And you can see he's gradually getting an aeration line creeping down that lung on chest x-ray. So I went home at this stage and we pushed on with this because it seemed to be getting somewhere. Hourly recruitment for a further 8 hours, 50 of PEEP, just once an hour, 2 minutes, just putting it up there. And I got a phone call when I was out of the hospital saying that this man had produced so much secretion that he filled the ventilator circuit and they had to swap the ventilator to a new ventilator. But amazingly, this lung was completely inflated, and not only completely inflated, but looked, I mean, there's a bit of patchy infiltrate there, but looked remarkably healthy. And he was able to stay on this for about another few days while hopefully he generated a bit of surfactant, and he was extubated to BiPAP where that lung remained reasonably well inflated. So here, again, quite a different technique, a different problem, and yet recruitment had quite an extraordinary effect. When can't you use it? Well, we're very careful. This is a high pressure manoeuvre, and you cannot use it when you've got incomplete resuscitation or an unstable circulation. It does produce a lot of hypotension. It's quite daunting, and if you haven't completed your fluid resus, then don't do it. We don't sedate for this manoeuvre, we don't fluid load for this manoeuvre, but we make sure our resus is complete. If somebody's already on inotropes, we'll turn them up a bit. If we don't do it in studies when there's a current or immediate past pneumothorax, we don't do it where there's a necrotising pneumonia or there's holes in the lung. We're not sure about COPD. We don't do it in studies for COPD, but I think in patients with combined lung disease, we would do it in COPD. But there's a theoretical risk that you might get more air leak in that condition. We just haven't seen it. And we don't do it in patients who've had ARDS for more than 5 days, although clearly this last patient, had lung collapse for 2 months. The manoeuvre we have is more sophisticated now. It's basically we've added one more step, and that is that we've got a 2-minute increment at the end. We go to the point of desaturation, but that's not our end point. We now go up again. We assume that once we've reached a point of desaturation, we've got our de-recruitment has happened, so we go back up for 2 minutes to the maximum and then go to the PEEP level above it, and we believe that's got our best PEEP. It's interesting that at the highest level of recruitment here, a number of things can happen. One is the blood pressure goes down low. Some people compensate well, others not so well. We don't worry about that much because it comes good in the next 2 minutes, provided it's not too low. If it's too low, we abandon it and we detect the fall at the pressure level beforehand. The other thing is a lot of people cough and splutter a lot at this highest level of PEEP. We used to be concerned about that and think we had to sedate it. But in fact, we don't increase sedation or paralyse these patients at all for this manoeuvre. And if they're coughing at this highest level, we believe that is the irritation due to expansion of chronically collapsed lung, and we believe that's a good thing and doesn't preclude success. Some people mobilise a huge amount of secretions at this thing, so much that you just have to suck them out. So it's doing a good thing, but of course we've all seen that suctioning completely sucks out all the recruitment that you've done. And we used to say, well, we've got to abandon it and start again. But now if they're tolerating it, we suck them out and we say, okay, we'll just reset the clock and we have your 2 minutes there after your suctioning and then we'll go back down. And that's generally has good effect. So, in conclusion, the staircase recruitment manoeuvres, which is the new sort of era of recruitment manoeuvres, we believe, and a number of other researchers believe, is much more effective than the 40-40 manoeuvre. This manoeuvre, with an alveolar pressure over 50, has a number of roles outside its routine application in moderate to severe ARDS. We use it a lot for ECMO avoidance, for veno-venous ECMO, of course, lung injury. We've used it during ECMO ventilation. We believe it has a role in lung atelectasis on the X-ray. It's got a role in independent lung ventilation. It's got a role in non-invasive ventilation. It's been shown to be of value in lung donors, and we believe it also can have a role in chronic consolidation. There's no randomised controlled trials of any of these things, and it'll be really hard to do because there's small numbers. But I think there's very compelling anecdotal evidence, and at least we are doing no harm, and therefore it's much more reasonable to try it. Thank you.